Hi, my name is Cindy Chiu. I'm a second-year fellow at the University of Washington. I'm here at RWCS presenting my case. It's a sore subject. This case involves a 34-year-old woman who presented to rheumatology clinic, who presented with months of oral ulcerations and pancytopenia. She was found to be HLA-B51 positive, and her pancytopenia was presumed to be autoimmune given their cyclic nature and her negative workup for malignancy. 2 months prior, when she went to rheumatology clinic, she was admitted to the hospital for pancytopenia and received IV methylprednisolone. Following that, she was discharged on prednisone 60 milligrams daily, and still her pancytopenia, her blood count still dropped while on a high dose of steroids. She later returned to the rheumatology clinic and was found to be off of steroids. She was found to have worsening oral ulcerations, and thus apremilast was started. However, her pancytopenia improved while off of steroids. A couple months later, she returned back to the hospital and she was found to have worsening ulcers, and she was also found to have ascites. And so there was a new diagnosis of non-cirrhotic portal hypertension. Just following that, 6 days later, she returned to the hospital. She was found to have pancytopenia, now new genital sores while on prednisone, and also was found to have this new rash as well as fevers. Due to her unusual response to prednisone, an extensive review of pancytopenia and immunosuppression was done by the rheumatology team and revealed equivocal benefit to her steroids. As you see in this first box highlighted here, she received pulse steroids, and you can see her counts improved. Each of these lines represent a cell count. Following that, she was still on high-dose prednisone and counts dropped, which we would not expect. Later during her hospitalization, on outpatient follow-up, she was no longer on steroids, yet her cell counts improved. And again, in the fourth hospitalization, she didn't receive any steroids, yet her counts also improved. This is an image of one of the rashes that she had developed during her hospitalization, and then also a representative photo of her oral ulcerations. As you can see here, it's mostly superficial erosion and sloughing of the buccal mucosa. During her hospitalization, her treatment included filgrastim. It also included total parenteral nutrition and also IV folate. She was never treated with steroids during the hospitalization. The only consistently helpful intervention in the hospital was IV folate and nutrition and hospitalization itself. And so due to this uncertain degree of this nature, this is why we had graphed out the steroid use and the trends with the pancytopenia. So in summary, this is a young woman who developed oral nasal ulcerations and inconsistently responded to anti-inflammatory therapy, but then developed non-cirrhotic portal hypertension, fevers, rash, and then new genital erosions. And so just due to this uncertain degree, we decided to do a broad spectrum toxicology urine screen, and that revealed methotrexate. And so this was revealed again on urine screen, blood serum, and then also showed drug toxicity on her bone marrow as well. So the diagnosis is surreptitious methotrexate use mimicking Behçet's syndrome. So the final takeaway of this poster is failure to respond to treatment or recognition of atypical features warrants investigating an alternate diagnosis and avoiding early diagnostic closure. So thank you and mahalo.